Elbow dislocation. Epidemiology. Second most commonly dislocated major joint, after the shoulder. Most commonly dislocated joint in children, 10 to 25% of elbow injuries. Common age group, 10 to 20 years. Posterolateral dislocation is the most common type, 80%. Pathophysiology. Mechanism of injury. Valgus posterolateral instability. Fuchs axial loading plus supination plus valgus force. Varus posteromedial instability. Fuchs axial loading plus supination plus varus force. Anterior dislocation. Direct window seat injury. Direct force to posterior forearm with a flexed elbow. Side swipe injury. Occurs when the elbow protrudes from a car window and is struck by another vehicle. May include anterior dislocation with associated fractures, humerus, olecranon, forearm bones. Progression of injury, Horry circle. Starts laterally and progresses medially. LCL fails first, commonly avulses from lateral epicondyle. MCL fails last, especially anterior band, which may remain intact. Classification. 1. By complexity. Simple. No associated fractures. Complex. Associated fractures, e.g., radial head, coronoid, olecranon. 2. By direction. Displacement of ulna relative to humerus. Posterior. Posterior. Posterolateral, most common. Posteromedial. Anterior. Medial. Lateral. Divergent. Sagittal plane. Radius. Anterior. Ulna. Posterior. Coronal plane. Radius. Lateral. Ulna. Medial. Clinical presentation. History of trauma. Pain and swelling. Gross instability. Loss of the normal equilateral triangle between the medial epicondyle, lateral epicondyle, and olecranon. Compartment syndrome. Neurovascular, NV, assessment before and after reduction. Imaging. X-ray, AP, lateral, oblique views. CT, for complex dislocations. Treatment. Initial management. 1. Closed reduction. Performed under anesthesia, sedation, traction and counter-traction in semi-flexio. Methods. Parvin method. Prone patient, downward traction on wrist, lifting the arm gently. Main and Quigley method. Traction, supination, flexion, pressure on olecranon tip. NV assessment before and after reduction. 2. Post-reduction immobilization. Assess stability by ROM. Splint elbow at 90 degrees flexion. 7 to 10 days, for simple and stable dislocations. 2 to 3 weeks, for simple but unstable dislocations. Avoid immobilization greater than 3 weeks to prevent flexion contracture. Operative management. Indications. Unstable or irreducible dislocation. Vascular injury. Open injury. Techniques. Open reduction without LCL, MCL repair. Reconstruction of ligaments as needed. Hinged external fixator for persistent instability. Delayed surgical intervention. Approaches. Posterior. Access to both medial and lateral sides. Coker. For radial head fractures. Medial. For comminuted coronoid fractures. Methods. Simple dislocation. Soft tissue repair, reconstruction hinged external fixator. Terrible triad. Radial head. ORIF, prosthetic replacement. Coronoid. Fixation. LUCL, repair, reconstruction. Postoperative care. Medications. Indomethacin, 50 mg T.D. S for 2 weeks, to prevent heterotopic ossification. Immobilization. LCL repair, flexion plus pronation. LCL plus MCL repair, flexion plus neutral position. Early active ROM encouraged to prevent stiffness. Complications. 1. Persistent instability. 2. Stiffness, loss of terminal extension is most common. 3. Neurovascular injury, ulnar and median nerve involvement. 4. Compartment syndrome. 5. Heterotopic ossification, due to multiple reduction attempts. And 6. Post-traumatic arthritis, from articular cartilage damage.